Good morning, everyone. Again, such an honor it is to be here today with you. And I wondered if we might be able to start. We're just so fortunate to have Charlene Webb here, and Charlene is a amazing leader. And I wondered, Charlene, if we might be able to tap on your wonderful ability to get us started in a good way.
Thank you, and welcome everybody. Good morning. If we can bow your heads. Father God, creator, grandmothers, grandfathers, we ask that you sit with us today, that you guide us and protect us with the work we need to do, the relationships we're building with one another for the betterment of our communities. We ask for protection for those traveling, that they may get home safely. We ask for special blessings for those fighting COVID and other illnesses, and give strength to our doctors and nurses at this very difficult time. We ask that you watch over our children, that they may be healthy and safe in our communities. In Jesus' name I pray, amen. Thank you.
Thank you so much, Charlene. And so just also very grateful to be able to bring land acknowledgement. And I think in the previous slide, you might be able to see our Pacific Northwest region, which is in the top quarter of the province. So geographically, very grateful once again to certainly say thanks for the opportunity to live, work, and play on the ancestral lands of the Haida, Tsimshian, Haisla, Gitxsan, Wet'suwet'en, Niska, Tahltan nations, as well as the nations identified below in the group of 25 amazing nations. So we acknowledge with the deepest respect and gratitude the opportunity to be here and to join from these amazing regions. I'd like to now take the time to introduce Laurie Flood, President and Chair of Metabolic Syndrome Canada, to share the next part of the presentation.
Thank you. So I'm the chair of Metabolic Syndrome Canada, which we affectionately call METSI. Just you might see METSI everywhere, just so you understand where that comes from. And this is a really personal story for me. You can see a picture of some very special people to me. This is my parents, Ken and Rachel Flood. And my mom had a surgery that didn't go very well over 40 years ago, which resulted in 30 more surgeries over a long haul. And our family spent quite a bit of time in hospitals, and we're a very close family. My dad's a very successful entrepreneur, and he spent a lot of time talking to doctors. And I don't know if you know many entrepreneurs, but they're entrepreneurs everywhere they go. So he would ask the doctors, if there was one thing you could change in healthcare, what would it be? And the answer that he heard more than anything else was, I wish my patients would exercise more and eat healthier. One of the doctors who cared for my mom was Dr. Gigi Boy, who's quite a renowned specialist in research in the field of gastroenterology, nutrition, and disease. And he and Dad spent quite a bit of time talking. And one of the ideas they talked about was a real practical clinical application of the best research. And of course, Dad, in his entrepreneurial way, started calling names he got from different universities across the country. And before long, he built a team of about 30 experts who volunteered to develop this practical program that we now call the CHANGE Program. You might wonder why. Canadians, 1 in 5 Canadians has metabolic syndrome, and most of them don't know it. It's not a well-known term, and it's a real crisis in our country. And diabetes and cardiovascular disease accounts for 43% of the deaths. This is, over 7 years old, these stats. I know it's getting worse, and the prevalence is getting worse. So by the time we're into the population of over 60 years, 40% of the population has metabolic syndrome. And we have a real opportunity to shift spending, trillions of dollars of spending, from treating these diseases acutely to prevention. So we created the CHANGE program in 2013. I think we finally got it going. it took a few years. We spent $2 million developing and then following a rigorous study with 309 patients in 3 different provinces in Canada to just demonstrate that the program we developed could be applied in different locations and still get great results. And it's Canadian Health Advanced by Nutrition and Graded Exercise is a mouthful, so that's why it's changed. It was coined by Dr. Gigi Boy. But we came up with the answer, the CHANGE program. And the goal was to help individuals go through all of the choices they have around health and exercise and diets and different things they can do and help them navigate through a team-based approach. And in 2017 and 2018, we supported a pilot in the Pacific Northwest of BC. And the results were more amazing than we'd seen anywhere else in Canada. And I think it's because the team is so innovative and resourceful and mostly committed to making a difference. And I think this is really where the story of Change BC began. I'm going to let Colleen continue.
Thanks so much, Lori. So just in looking at this Change BC work, why is it really important? And probably many of you are so aware of this information, but over 1.5 million people in BC have diabetes or metabolic syndrome. The annual cost, $2 billion in BC for diabetes, the health system, $509 million. And just every year, for patients, out-of-pocket expenses between $800 to $4,700 are some of the estimates we gathered with the knowledge of our physician leaders. And at the end of the day, an effective primary care team is really what's needed. I had the opportunity to join the Pacific Northwest Division as their executive director back in 2016. And one of the areas that was really evident is that there really wasn't anyone to help the family physicians. We have the best, I would say, I'm going to say in the province. We have the most amazing and innovative group, but there was no one helping the family physicians. So we thought that this is a great way to try to build a collaborative primary care supports by taking a look at opportunities such as working with Metabolic Syndrome Canada. So we applied for a grant, we were successful. And one of the areas that the physician said is, boy, let's look at what we can do to work with kinesiologists. And so had the great fortune to reach out to Dr. Robert Bushel. He graciously accepted my call and also saw that there could be a synergistic approach to have perhaps look at primary care transformation. So through those connections, we've been able to build a treasured UBC partnership with academic expertise, exceptional student learning opportunities in the Pacific Northwest communities. And Dr. Bushel has led to further amazing partnerships, such as with Dr. Ricky Yada and the School of Land and Food Systems in the dietetics program. We have about between 40 and 50 partners that gather every Friday morning at 7:30 till 8:30. And that includes family physicians, health authority partners, elders like Mary Lou. We have 2 health authorities, Northern Health and the Niska Valley Health Authority, Indigenous health directors like Charlene, amazing partnerships with Doctors of BC, the GPSC, General Practices Services Committee, Shared Care, all working together to really transform primary care. And I should say too, that in our region, our patients actually live 10 years less in the Pacific Northwest than if they were living in the Lower Mainland. So we have a really enhanced responsibility to do what we can to offer equity for our region. So I'd like to now turn the presentation over to Dr. Anara Odo. Dr. Odo is our board's director and secretary for the Pacific Northwest Division of Family Practice and also a clinical instructor with the Department of Family Practice, Faculty of Medicine, UBC. Dr. Odo.
Thank you, Colleen. Yeah, there is a strong relationship between primary care and Change BC. We all know that the primary care is the foundation of successful medical system, and interprofessional team approach to patient care is the pillar. But unfortunately, this interprofessional team approach has been missing But in the last few years, the Ministry of Health and the Health Authority are working closely to promote interprofessional team approach to patient care in primary care settings. Fortunately for us, Change BC has both priorities. It's a primary care program and it's an IPT, meaning interprofessional team model. So it has, what is needed, to make changes on the health and the lifestyle of patients. And knowing that most patients actually got into health system through primary care. So if we can make those necessary changes, that will help not just to coordinate the care of the patient moving up forward, but also to prevent, some diseases from, progressing and developing complications. An important thing with, Change BC is that a patient-centered approach to care. So if you look at the photo on the screen, you can see that the patient is at the midpoint and there are different providers, wrapping care around the patient. This is what we do on Change BC. We try to sit down with the patients and find out what exactly we need to do to help promote the care and prevent, progression of disease in this patient, working primarily on the lifestyle, which is basically the diet and the exercise. So unlike many other cares, that is a bit disjointed, this patient gets, a holistic, team-based, care and, support. This slide is all about, the opportunities that comes with, Change BC. And our target population is adults with or at high risk of metabolic syndrome. And metabolic syndrome is actually a syndrome, meaning that there are different disease entities that comes together to form this. And there are 5, criteria. 3 of them, if present in a patient, the patient qualifies for the diagnosis. Now, one of them is, obesity, which is common in our society, high blood sugar, which is, translates to diabetes, hypertension, and having an abnormal level of cholesterol. Change BC is not all about therapeutic care, it's also about prevention. So we included patients with the 2 criteria, patients that have high risk of developing the 3rd criteria, and then a confirmed diagnosis of metabolic syndromes. With that, we are able to prevent patient that has 2 criteria from developing the 3rd one, thereby preventing metabolic syndrome. And patients that have metabolic syndrome as already, this model provides a treatment pathway that helps to prevent the progression of the disease, prevent the complication, and at the same time to reverse, the criteria so that at the end of the program, a good number of patients do not meet the diagnosis of metabolic syndrome. So the target clinical goals for metabolic syndrome is to prevent and to reverse metabolic syndrome on our patients, and also to prevent complications that, could result, from metabolic syndrome, and at the same time to improve the general health and wellness of the population. This is important because the program involves the family physician that knows the patient very well. It also happens in the community of the patient that the patient knows very well. It introduces the patient to resources that may be existing that he or she never know about. There is peer group and peer support. And there is also support that improves the mental health of the patients. So at the end of the day, the patient does not get only care for the metabolic syndrome, but there is a significant improvement on the general well-being and health of the patients. Next slide, please. So there are different programs outside there that talks about, diet and exercise, but Change BC is different. And this has information that makes Change BC different from other programs. Number one is that there is a family physician leadership, and we are talking about a family physician of the patient, a physician that knows the patient in the same community of the patient, a physician that is there to provide support for the patient during the program and after the program. So this is important because you are not just there for the program that runs for a period of time, but you are there with people that are going to provide the support and ongoing. And because the family physician that knows the patient is part of the team, some of the information that are needed, to provide appropriate care with the patient is already existing. So it's easy for patients actually to join and participate in the program. Another thing is that it's community sensitive. In as much as we try to preserve the core components of the program, we also know that different communities have different resources available to them and the needs are different. So the program is modifiable, trying to create a program that fits into different communities based on available resources and challenges. It is a personalized care. in the sense that, we take into consideration the social and psychological aspect of the patient, knowing that some patient may not be available to do exercise at a particular point, or patient may have some, mental health challenges, or there could be issues with employment that affect the patient availability and extend the patient can perform in the program. So we put all those into consideration, having a meeting with the individual provider and with the team, and an ongoing assessment, just to make sure that the patient gets the best out of the program. There is a team approach, which I have mentioned, which is very huge. Now, in addition to the regular schedule follow-ups, there is a provision for check-in. So patients actually have to meet with the team at a regular interval. And if there is need in order for the patient to fall back to the team for any check-in purpose, the patient is able to do that. So there is a strong connection with the participant of this program. And knowing that this is happening in the patient community is huge. Knowing that it's happening within a team that the patient is familiar is huge. So it's easier for the patient to connect and to check in, with the team. The patient is being empowered. So it is not just providing care, it is having the patient to participate on the care and also be at the center of the care. So there's a lot of education, and the patient is being empowered with knowledge of the disease condition, the medication that are involved, and at the same time, develop some exercise which is prescribed and is specific for the patient condition. Patient is given enough time to learn about this exercise so that he does it at home and is able to continue with this even after the period of the program. There is adequate time for the changes to be made. It is a 12-month program. It is not 3 months. It is not 6 months. And the time is important and huge here because it takes time for change to happen. So this is one of the peculiar and the big benefit with this program, that the patient have enough time to get to know about the disease, enough time to develop the skill, practice the skill before the end of the program, so that at the end of the program, the patient has enough, is well empowered to continue, the skills and maintain, the impact developed during the 1-year period. It is all about relationship and ongoing support, and having the family doctor that continues to provide the care for the patient after the 12 months is huge. Working with a team that the patient is familiar, that the patient have a good connection, the patient can check in with is also huge. So Change BC is different from other exercise or diet program outside there because of these peculiar features. Next slide. So we are not looking at the clinical outcome of the program only. We also look at the patient experience and the feedback, what they have to say about the program. So after the pilot program, we had a survey of the participants, trying to get feedback from them on what they think about the program, the level of experience they had, and how empowered are they participating in the program. And 100% of patients agreed that the Change BC was relevant to them. 100% also agreed that the program helped them to understand their health issues, which is important. This is where education, knowledge, and empowerment plays a lot of role. 80% of them agreed that the program increased their knowledge of health support available to them. Most people do not know before now that kinesiologists are a strong and a good member of a health team. Even for example, the Ministry of Health is working in the last few years on primary care network, which Greg is going to talk more about. So that program includes a family physician with allied health workers to support the physician in primary care setting. And kinesiologist wasn't included on the list of the allied care workers. But because we have had experience which is huge, during the pilot on how kinesiologists and the learners in that department were able to make a lot of changes on the lifestyle of the patient, we at Pacific Northwest Division of Family Doctor actually pushed that kinesiologists should be included on the list, and that was successful. So there is now an approval for the kinesiologists to be one of the funded members of the primary care network team, which is one of the ways we are hoping to sustain this program and also to expand it across the province. 61% of the participants agreed that the session with other patients added value to them, because there is a peer support, there is also a group support. So people with similar medical condition coming together, having some discussion is huge. So participants agree that having this group component of the program was helpful to them. And 100% agree that seeing a dietitian and a kinesiologist alongside with their family physician added value to their care. So these are some of the reports or the feedback we got from the patients that participated in the program. Thank you, and I'm going to pass it on to Greg.
Thanks, Sonora. So what you see before you here is a slide of the province with health authorities in different colors, and then stars and circles that relate to local divisions of family practice in BC. And there's actually 36, I believe, divisions across BC, and the Pacific Northwest Division of Family Practice is occupying the greatest geographical territory in all of BC. And while you don't see it officially in this slide, it is part of the gray area in the top half of the province. So one of the mandates of divisions of family practice has been to improve community delivery of primary health care across the province. And so with many divisions across the province creating novel community projects to demonstrate innovation in primary care, we've had a lot of opportunity to see some innovative ideas, but we haven't seen those ideas take the next step, which is to take a concept and make it scalable. And the CHANGE program is our flagship opportunity to take that next step. So what we want to achieve here with the CHANGE program is to embed it in primary care networks. So primary care networks, or PCNs, are the province-wide new vehicle created by the provincial government for delivery of accessible primary care in community. And PCNs are grassroots collaborative community stakeholders, including divisions of family practice, health authorities, academia, and in the Pacific Northwest, that includes both UBC and UNBC, and local stakeholders, as well as industry. And PCNs are funded in a stable manner in 4-year cycles by the Ministry of Health. And in the Pacific Northwest Division of Family Practice region, we have at least 5 of these PCNs. Some of the most remote communities in the province are represented here, and all of them are committed to the delivery of the CHANGE BC program. CHANGE BC as a collaborative organization includes UBC, has the opportunity to be involved in a socially responsible, culturally appropriate, scalable program for the entire province with stable PCN funding, starting in the Pacific Northwest, which takes a bold step towards delivery of a preventative healthcare program, which is the first of its kind across the country. And so you can see here in the slide, we've got the territory represented by the Pacific Northwest Division of Family Practice. And in the green, you have the communities that were originally partaking in the pilot program for CHANGE BC in 2017-18, with Houston, Smithers Terrace, and Masset being involved. And in the brown, you see represented the names of the PCNs incorporated within the division, the Pacific Northwest Division of Family Practice: Bulkley Valley Wet'suwet'en, Coast Mountain, Kitimat Haisla, Prince Rupert and Coast Simpson, and Haida Gwaii. So those are all the PCNs involved. So rural physicians wear many hats in their communities. As I indicated at the beginning of the introductions, I'm also a site director for the Rural Northwest Family Medicine Residency Program based in Terrace. as well as a preceptor for the integrated clerkship third-year medical program, also based in Terrace. Educating learners in our programs in the northwest corner of the province fulfills a rural education mandate within the UBC Faculty of Medicine. We are also fulfilling a UBC strategic mandate by engaging in a multidisciplinary educational model, including med students, student nurses, and family medicine resident physicians. UBC has the opportunity now to include kinesiology and dietetics in that multidisciplinary team education model by incorporating the CHANGE program with sustainable funding through PCN initiatives across the Pacific Northwest. I'd like to hand the torch over now to Dr. Boucher.
Thanks, Dr. Linton. I'll talk from the UBC and perspective and student experiential learning lens, where we have engaged students with this amazing group of people in the Pacific Northwest and the really effective program of CHANGE. And through the recent work that we've been mounting within the scope of work integrated learning at UBC for kinesiology students. So just a little bit of background, our relationship or the relationship between the school at UBC and the Pacific Northwest Division began in 2018. I received a call from Colleen Enns describing the division and the CHANGE program and her interest in kinesiologists being part of primary care in the North. And I was immediately struck with excitement and enthusiasm that a division of family practice in primary care had this innovative thinking, recognizing the value of kinesiologists in chronic disease prevention and health promotion. I was very excited about this because students in kinesiology are really interested in clinical setting and experiential learning, and we were nimble enough to have some positions that we could allocate to work in the division through a co-op program that we had. And quite quickly, we were able to situate students directly in the clinical setting in the division in the North in Haida Gwaii Terrace in Houston. And that coincided with the launch of a pilot program of the CHANGE program that in the first year saw this remarkable change in remission of metabolic syndrome. Perhaps Deanna and Jeff will appreciate the schematic on the right, recognizing the powerful effects of exercise in health and specifically in metabolic health. We endured COVID, but we kept planning, and we were working on a sustainable model for implementing the CHANGE program and also looking for further developments in the educational side of things for students. And at the time in 2021, we made a strategic decision in the school to shift from a co-op model to a work integrated learning model, principally around offering students a different kind of experience with primarily more engagement directly with faculty members within the core curriculum of the school that created a synergistic continuum of learning from core courses in the kinesiology curriculum. And at the same time, enriching the structures and supports for this collaboration in primary care by aligning with some of the strategic initiatives at UBC, specifically the school strategic plan responding to students' keen interest in experiential learning, and for us to provide exceptional learning opportunities for students. Also responding to UBC's Indigenous Strategic Plan, and also aligning well with UBC Health Strategic Plan, both in learning for students, but also system change and also the rural and remote perspective. So what we have done and what we were mounting is work integrated learning courses. And I've put here the one specific course, work integrated learning, that currently is a pilot course that will be launched in the fall, that will be developed and evaluated proceeding to full Senate approval. That is a work integrated learning course. So it's experiential learning for credit, aimed specifically to support the learning objectives and experiences of students directly with change. And it also then has built-in features that are integrated with UBC, and that is students will be required to take UBC 2324, which is the Indigenous Cultural Sensitivity course, and also aiming to incorporate some of the modules of TBC on the Run, where for students to learn about team-based care. And this course is one of a number that is being mounted in this new work integrated learning model. In addition to that, we will direct opportunities for students to do research through credit courses that will supplement the clinical experiential work with research that will be vital for the comprehensive approach to understanding the value of change for primary care. And also at the master's level, then we have the opportunity for similar research engagement of master's level students. So as part of the planning with this educational model, and also looking at sustainability within the Pacific Northwest for change, we were fortunate to recruit 13 kinesiology students this semester who've been working virtually and looking towards implementing a new round of the change in person, but also taking advantage of the skills we've learned in the virtual space to mount two components of change going forward. And students will have been remarkable, innovative, and just a fantastic team of talented students who are really making changes and ready to launch already next month, both in person and virtual. And the model is that students enrolling in academic courses, work integrated learning courses, and then the directed research studies will then be under the supervision and mentorship of a faculty member in kinesiology, but also for professional scope of practice and quality assurance of activity, they will be also supervised by an exercise physiologist certified within our outreach program, staffed by the school through an exercise physiologist, and then the engagement within the team in the Northwest, rolling out change on a sustainable level. And we were delighted this past year receiving this mail from Colleen, and I think this really is pertinent for everyone here, looking at the approved primary care network allied health professional disciplines. And in red there, you can see kinesiologists, which has officially been approved and recognized as part of professional practice within primary care networks, along with all many other professional disciplines. So we're thrilled about this. This has been long in the waiting, but the recognized value of kinesiologists as part of team-based care is now in place, thanks to the remarkable leadership of Colleen and the physicians and the team up in the north to make this happen. Ricky messaged me to take over for him. He unfortunately had to leave, but a critical part of the change team working with the Pacific Northwest has also been, in parallel with kinesiology, the engagement of dietetic students. And a similar approach is being mounted to recruit dietetic students through Faculty of Land and Food Systems, their program there. Maybe some on the call are familiar with the discussions and planning around this together with Tamara Cohen. Filling the kind of model around change where dietetics and food science and even linking to oral health, which Carrie will talk about next, really is building this comprehensive interdisciplinary team and creating these amazing opportunities for students. Over to you, Carrie.
Okay. Well, I'd like to start by saying I was first really inspired by the innovation of Change BC in relation to how they were incorporating students into the team in really real and relevant ways, which you'll hear about in just a second. So that prompted my interest. And then when I started to learn a little bit more about the team, of course, I've been a strong advocate as a dental hygienist for over 35 years of linking oral health with systemic health. And in my practice, I have seen many times evidence of systemic disease that manifests orally. And one of the real strong links with that is with metabolic disease, and in particular with HbA1c levels. We can actually see a real change in a short period of time with treatment of gum disease and the regulation of the HbA1c, and vice versa. With better regulation of HbA1c, we are also seeing improvements in periodontal health. So I really see a role for oral health care in primary healthcare teams that could advance efforts to prevent and manage diabetes, as well as other parts of the syndrome of metabolic disease. And we know that oral health issues and systemic diseases share many common risk factors, as Dr. Oder mentioned, including things we need to think about: the social determinants of health, diet, exercise, and smoking. These all play a role in those inflammatory markers. So we're just early days exploring how this might look, but I'm delighted to be part of those discussions. And I'm going to turn it over to our illustrious student team to tell us how they innovated within the teamwork.
Hey everyone, thank you for that, Carrie. So as you can see on the right side here, we've got our beautiful Change BC team for this year. A little bit about the composition about our student team. We're comprised of 3 master students, including myself, Carmela, and Vienna, which we'll talk later in just a little bit. And we've also got 10 undergraduate students that make up the student team. So our student team is comprised of 3 pillars that we've created to map out the Change BC aspects. So we've got the logistics and planning team, which basically plans and coordinates the workshops, tallies minutes, and creates general group organization. And then second of all, we've got the community engagement team, which is basically they bring out the different cultural significances in different areas, talk about health barriers that lead to more applicable exercise prescription, and help understand the rural areas that we will be promoting exercise in. Finally, we've got the exercise prescription. That's the one that I lead. And we actually plan the exercise programs. We create circuits and tailor the exercise. So it provides a little bit more of a hands-on application there. We can talk a little bit about the actual experience that students have gained from the Change BC program. So we've provided a little bit of a mentee over here that kind of sums up a little bit of the experiences that students have gained throughout the Change BC program. So, there's words like inspiring, teamwork, inclusivity, beneficial, the aspect of providing value. And I think that really sums up our student experience very well, as really teamwork and enlightenment and the sense of value is present throughout the whole program here. And as a group, we've worked through and really got the chance to apply our knowledge as kinesiology students into a real world scenario, which is something honestly a lot of university classes lack. So having this as a supplement brought in a different perspective to kinesiology. It encourages a lot of student-led and student-to-student learning, which builds a great communication and leadership skills, as well as making some great friends, because nothing brings students together more than a 7 a.m. Friday meeting. So that was awesome to have that. And honestly, all in all, if we had to sum up the experience in a few words, it would be just to bring in applicable portions that kinesiology students require as professional kinesiologists into the university experience. So from here on, I'll be passing it down to Carmela.
Thanks, Ahmed. I'm going to talk a little bit about kinesiology and our role in healthcare. So like Dr. Wichel mentioned earlier, it was really groundbreaking for kinesiologists to be acknowledged as part of a primary care team. So I'm going to demystify a little bit of that for those of you who may be less knowing about our practice. So kinesiology, simply defined, is the study of human movement, performance, and function. This simple definition might be in part why kinesiologists still get mistaken for glorified personal trainers, but our reach is much broader than that. Training is for everyday people. We also treat patients because rehab is training in the presence of injury and illness. And we train athletes too, because performance is training beyond the goal of health. What they all have in common is the goal or the need to move better for their quality of life. Kinesiologists work with people from end to end on the spectrum to accomplish this. Our education is more interdisciplinary than just anatomy, physiology, and exercise. We are knowledgeable in movement psychology, sociology. We learn human behavior because we understand that knowing what to move and how to move is really just the first step. Helping patients understand why they should move different and helping them move differently every day for themselves is our real challenge. Changing how people move takes more than just an educated professional. It takes time. This is how kinesiologists become a serious player on the primary care teams, because our practice allows us the gift of time. A regular visit with us is minimum 45 minutes to an hour, at least once a week, sometimes two, and maybe even more with the advancements we've made in the virtual space, thanks to COVID. We have time to connect with patients meaningfully and earn their trust, to foster and support them through the hardest thing to do, change. Changing how they move and how they behave. Because sustainable behavior change is lifestyle change. This is the lifestyle change that combats chronic disease. It costs less on healthcare, and it offloads the care plates of our overworked primary care teammates so they can have more time to practice their specialty best. All that said, kinesiology is still an imperfect practice. We have yet to be college regulated, but our practice education at UBC is definitely evolving in the right direction. Our unique team of students at Change BC and young professionals who work and study along the spectrum have seen the education and practice gaps firsthand, and they've turned it into passionate work. I'm going to toss it over to Vienna so she can expand more on this.
Thanks, Carmela. So yeah, I'll dive in a little bit more on just our student experience as students in the School of Kinesiology at UBC. This has been an incredible opportunity for us as undergraduate and graduate students to really critically think about and engage with what we've learned in our courses. Often healthcare is taught through a deficits-based approach in our courses. So we talk a lot about the incidence of disease, systematic disparities, and the lack of funding, especially for exercise, which is super important to learn about as students. But I think it often leaves us feeling a little bit frustrated because we do feel like we're quite far away from being able to make a difference. Through this opportunity with Change BC, we've really gotten to directly apply this knowledge to a healthcare setting, which has been awesome. The Metabolic Syndrome Canada team and healthcare professionals in the Pacific Northwest Division have mentored us through a strengths-based approach. So we've learned through the successes of the past and current CHANGE program across Canada and celebrated the diversity of the Pacific Northwest Division and how this can further strengthen the virtual delivery and in-person delivery of our program. As students, we've had this rare opportunity to address gaps and challenges that we learn about in the classroom and apply these to the ideas that we bring forward to the group, like at the same time. It's been awesome listening to students be like, hey, I learned about this in class today. And now we're going to talk about how to address this challenge and how we deliver the program. Last week, Carmela, Ahmed, and I met with Dr. Vushal just to discuss what we are presenting on in this meeting. And he just asked us, like, how has this worked so well so far? First, we have an incredible group of students who are so eager to show up. It's been mentioned a couple of times, like we have multiple 7:30 a.m. meetings, which is not the easiest thing as students right now, but everyone shows up so ready to collaborate and discuss and just work on pushing this program forward. And I think we can speak for all of us when we say we've been so fortunate to work with the professionals that have given us the opportunity to learn and apply with our own autonomy this knowledge and impact the virtual delivery of Change BC. We are constantly being offered support through different contacts and resources and perspectives. We've really felt valued as students, and we feel like we have a genuine seat at the table, which I don't think many kin students can say when it comes to a healthcare or professional setting like this. And we just really hope that this model continues. Thank you. I'll pass it on to Mary Lou.
Thank you. My name is Mary Lou McKay, and I am an elder from the Nisga'a Nation. I would just like to say that I am very thankful and very overwhelmed learning all about Change BC. I'm thankful for them coming into our beautiful Nass Valley. This picture that you see in the background is my backyard. I like the idea of feeling supported on a personal level with the caregivers, that our team, as was said earlier, work as a team in helping prevent or intervene with a metabolic syndrome. The caregivers make each individual feel like they're walking hand in hand to help us reach our goal, and not just going through the motions as we have been in the past just to get through a program. To think that diabetes was just treated in a certain way, but now with this new program, I feel like we have more support and the opportunity of our community learning how to prevent diabetes in a new way, in a way that we've never ever combated it before. So I look forward to having the opportunity to educate our children and our grandchildren to break the chain of diabetes, because we have such a high rate in our community and in our valleys. I look forward to seeing the program initiated and actually happening in our community. I know it's not that far away, but we all have a new hope for new change. Thank you.
Arlene, we're grateful you're here today. Could you say a few words?
Thank you. Amazing work. The benefits I see that Change has to offer for our community members is the one-on-one support. We also tie in our diet, our traditional foods, to how we are managing one's health. This is learning opportunity for the staff to how we can incorporate the kinesiologists into our work plans here in Kitsilano. We've been talking with our community members of the benefit of having a kinesiologist, and we've heard some positive feedback, because the ones we really want to target is the prevention piece. When we start talking and learning about our traditional foods and how not only how where it's gathered, but how it's prepared, is an amazing opportunity for the students to connect with how we live our lives. The food we eat, the physical activity we do to harvest the foods. I believe what the kinesiologist can bring to our communities is a healthier, strong start as we move up in age, so to speak, and or to manage to help our aging population and our elders to manage with their chronic illness. So it's been amazing to be part of the early morning phone calls, which I truly appreciate. It's helped me look at my world different and the work that we do here at the health center. Thank you.